Okay, imagine this scenario. You're tackling a clinical question, maybe you're reviewing notes for revision, or perhaps just thinking about common presentations.
Hmm.
And you see that phrase, breast lump. Immediately, your mind starts racing, right? What could it be?
Yeah, absolutely.
More specifically, what's the most common benign cause? And crucially, how do you quickly pull those essential facts to mind about it?
That's exactly the situation we're diving into today. So, welcome. We've got this source material right here, these detailed notes, and they're all focused on cracking open that very thing, breast fibroadenoma.
That's right. And our mission in this deep dive is really quite focused. We're going to unpack these specific notes that we have, highlighting the really crucial points, for understanding and remembering everything.
From what it is to how it's investigated.
How it's managed, yeah. Think of it as a way to get these particular facts locked down for revision, make sure they really stick.
Exactly. Consider this our joint walkthrough of this material. We'll pull out the bits that seem most important, talk about how they connect, and, think about those details that are probably the most high yield for recall, just as the notes seem intended.
Perfect. So let's just jump right in then. According to this source material, what is a breast fibroadenoma at its core? What's the sort of fundamental definition they give?
Right. Well, right at the start, the notes give us the key identifiers. It's described as a common benign breast tumor. So two absolutely crucial points right there.
Okay.
It's widespread, and importantly, it's not cancerous.
Common and benign. Okay.
And it's highlighted as being the most common type of benign breast tumor.
Got it. Common and benign. Those are definitely the absolute must-know starting points.
Yeah.
What's it actually made of, though? Structurally speaking, what do the notes say?
The notes specify that it involves both glandular and fibrous tissue. They go into a little more detail later, saying it comprises stromal and epithelial tissue originating from the breast's duct lobules.
Oh.
So basically, it's an overgrowth of the normal structural bits, that's the stromal and the lining cells, the epithelial cells, that make up part of the breast's milk-producing units.
Got it. So a localized overgrowth of those specific breast tissues. Now, clinically, like before you even get to imaging or anything, what's the classic sign? What does it feel like? This material is quite specific.
Yeah, this is probably the most memorable part. The notes describe it as a firm, rubbery breast lump. And vitally, it's typically painless and mobile when you feel it.
Mobile.
Yeah.
That really is a key differentiator, isn't it? Something that moves freely versus something kind of stuck.
Absolutely. And the notes give a fantastic analogy to help that mobility point stick. They actually call fibroadenomas breast mice.
Breast mice.
Yeah. Just picture a little mouse darting around under the skin. That's the kind of slippery, movable quality you might feel on examination. Firm, rubbery, painless, mobile. That breast mouse image is a really high-yield memory hook from these notes.
Breast mice. I like that. It instantly makes you think of it moving around. And who is most likely to present with one of these, based on this information?
Well, the notes emphasize they're most prevalent in women of reproductive age, particularly common in young women.
Right.
They even give a specific age range later on, saying they primarily affect those aged 15 to 35 years. While they can happen at any age, that younger reproductive period is where you most expect to see them.
And is there a reason given for why they're more common in that age group? The notes seem to hint at a connection.
Yes, they definitely link them to hormonal influences. They explicitly mention they're often related to estrogen surges, which makes perfect sense, given the demographic.
Oh, okay.
It just reinforces the idea that these are tied to the hormonal environment of the breast. And an interesting little detail tucked in here is that around 30% of them might actually shrink spontaneously over about 2 years, so they're not always static.
Right. That's interesting. So boiling down those initial points from these notes, most common benign involves that glandular and fibrous tissue overgrowth, feels firm, rubbery, painless, and mobile like a breast mouse. Strongly linked to reproductive age and estrogen, and they can even shrink on their own sometimes.
Precisely. That covers the basics really well. Now, let's touch briefly on the why, the etiology and pathophysiology as described in this material.
Okay, the cause and how it develops. What do the notes say about the actual cause, the etiology?
The etiology, the underlying reason why they start growing is simply stated as unknown in these notes.
Well, that's easy enough to remember. Unknown cause.
Okay. And the pathophysiology, how does it actually form once it starts?
But the notes connect this straight back to the hormonal influence we just mentioned.
Oh.
The pathophysiology is described as that overgrowth of the glandular and fibrous breast tissue, and that hormonal stimulation, particularly estrogen, Plays a significant role in this formation process.
Okay. So, unknown trigger, but the process seems to involve hormone-driven overgrowth of the breast's building blocks.
Concise and clear. Seems like that's the aim of these notes for revision.
Right. Moving on from the basic what and how it forms, the notes list factors that might increase someone's likelihood of developing one, the risk factors.
Yes, the sort of predisposing things. So the notes list a few key ones. First, age specifically, as we said, the reproductive years, though they do acknowledge it can occur at any age.
And tying back to that age link, it sounds like hormonal factors are a big one.
Absolutely.
Yeah.
Hormonal factors are listed next, reinforcing that estrogen connection again. The notes mention things that kind of increase exposure to estrogen over time or during key periods.
Like what specifically?
Things like early menarche starting periods, young late menopause, so stopping periods late, nulliparity, which means never having given birth,
Right.
and also the use of HRT, hormone replacement therapy.
So basically anything that sort of prolongs exposure to or elevates estrogen levels seems to be a factor based on this material. That's the pattern suggested, yeah. And finally, the notes mention family history having a first-degree relative, like a mother or sister who has had fibroadenomas or other breast conditions.
Okay. Age, various hormonal factors linked to estrogen and family history. A pretty standard trio of risk factors for many conditions, but definitely valuable to see them listed out clearly from these notes.
The material also includes some epidemiology, giving us context about how common these are, specifically mentioning a UK focus.
We already heard it's the most common benign breast tumor, which the notes repeat here.
Correct. And they really nail down that primary age group again, emphasizing that 15 to 35-year range we talked about.
That age range really does seem like a crucial detail for recall.
It certainly is. The notes also make a point of mentioning that fibroadenomas seem to be more prevalent in African-American women.
Okay.
And here's an interesting little detail from the notes that might stick with you, precisely because it's a bit odd. The overall UK prevalence is listed as not known.
That is curious. The most common benign breast hair prevalent in a specific young age group. But we don't actually have an overall count for the whole UK population. It's one of those details that makes you pause, which might actually help you remember it.
Exactly. It adds a layer of nuance, doesn't it? Even to something seemingly straightforward. Now, let's shift gears to a really critical clinical step. If you encounter a breast lump with those classic fibroadenoma features, that firm, rubbery, mobile breast mouse feel, what else could it possibly be?
Ah, right, the differential diagnosis.
Exactly. This is where the differential diagnosis comes in, and the notes give us a key list.
This is where you need to run through the possibilities in your head, isn't it?
Right.
What does this material list as the conditions that could mimic a fibroadenoma?
Okay. The notes give a list of 5 crucial differential diagnoses to consider. Breast cysts,
Okay,
Phyllodes tumor,
right.
breast cancer,
Yeah.
obviously,
Mm-hmm.
lipoma, and papilloma.
Okay, so that list. Cysts, Phyllodes tumor, cancer, lipoma, papilloma. That's your mental checklist when you feel a lump. Thinking about that list, just from the names, you can already sort of start categorizing them in your head, right?
Yeah, you can.
Some are benign, like the fibroadenoma itself, cysts, lipoma, papilloma, but others, crucially, have malignant potential, like the Phyllodes tumor and, of course, breast cancer.
Absolutely.
The notes are clear that these are the possibilities you absolutely need to consider and, potentially rule out.
Definitely. That list is presented as essential knowledge for differentiating. Now, let's circle back just slightly to the clinical presentation section. The notes give us a bit more detail here that kind of adds depth to that initial description we had.
Right, like adding more brushstrokes to the picture of what you'd actually observe and feel.
Precisely. The notes reiterate the key lump characteristics. Typically painless, firm, and movable. They give a common size range too, noting they are often less than 5 centimeters. And usually unilateral, so just in one breast.
And any changes to the overlying skin or the nipple, that's always something to look for.
The notes explicitly state that skin or nipple changes are usually absent. They mention that dimpling or retraction, pulling into the skin, rarely occurs. So their absence is actually a helpful feature pointing towards a benign diagnosis like fibroadenoma.
Right, the lack of those potential red flag signs is reassuring. And this section brings back that vivid breast mice analogy again, emphasizing the rubbery, well-defined, and mobile feel. It really does stand out in these notes as the core description.
It does. The notes also repeat that the upper-outer quadrant is a common location to find these.
Okay.
And they mention again the possibility of them being multiple, especially if there's a positive family history.
So just to consolidate the clinical picture from these notes, You're looking for a painless, firm, mobile, rubbery, well-defined lump. The breast mouse, often under 5 centimeters, usually unilateral, and in the upper outer quadrant, typically no skin or nipple changes, though they can be multiple if there's a family history. That paints a pretty clear picture.
Yeah, it does. So with the clinical presentation and differential diagnosis in mind, the next logical step in the pathway is obviously investigation. What does this material tell us about how you actually figure out if a lump is a fibroadenoma?
It outlines a kind of step-by-step approach, doesn't it?
It does, yeah. It starts with the clinical breast examination. So that involves both palpation, actually feeling the breast tissue, and any lumps and inspection, looking for any visual changes. That's always your starting point.
Makes perfect sense. Then imaging comes into play.
Yes, and the notes give a really critical piece of information here about choosing the right imaging based on age. Mammography is recommended for patients who are over 40 years old.
Okay, over 40, mammogram.
But for younger patients, those under 35 years old, ultrasound is the recommended imaging modality.
Yeah, under 35, ultrasound.
MRI is also listed as a possibility, but it's the mammography and ultrasound that have that specific age guidance attached in these notes.
That age cutoff for imaging, 40 for mammography, 35 for ultrasound, that feels like a really high-yield detail for revision. The notes don't explain the why exactly, but they give the clear instruction.
Exactly. The instruction is what's provided. It's about what you do.
Yeah.
And after imaging, what's the potential next step mentioned?
Biopsy. The notes state that fine needle aspiration, or FNA, where, a fine needle takes a sample of cells, or a core needle biopsy, which uses a slightly larger needle for a tissue sample, might be performed.
Right.
And the notes tell us why these are done, basically for confirmation of the diagnosis, especially if the imaging findings were a bit atypical or not completely clear-cut.
Okay, so according to this material, the diagnostic flow is pretty clear. Clinical exam first.
Yep.
Then imaging, guided by age, mammography 40, ultrasound 35.
Right.
And then potentially a biopsy, FNA, or core needle if you need confirmation, or if the imaging looks unusual. That sequence is a solid pathway to remember.
Okay, so we've covered identifying the lump, thinking about the other possibilities, and the investigation pathway from these notes. What happens once you've confirmed it is a fibroadenoma? How is it managed specifically in the UK context described here?
The notes present two main routes for management, really. It's either observation monitoring or surgical removal.
Okay. When would simple observation be the right approach, according to this material?
The notes indicate that small asymptomatic fibroadenomas, those classic painless breast mice that aren't actually bothering the patient, can often just be observed and monitored regularly. Keep an eye on them.
Right. And when is surgical removal the way to go? The notes list some specific indications for actually taking it out. For excision?
They do, yeah. Surgical removal, which is described here as excisional biopsy or lumpectomy, basically removing the lump, is indicated in several scenarios laid out in the notes. The first one listed is if the fibroadenoma is larger than 3 centimeters in diameter.
So size matters. Over 3 centimeters is a clear threshold mentioned in these notes.
Yes. It's also an option simply based on patient preference. If the patient would just rather have it removed, that's a valid reason, according to this material.
Patient choice. Okay, what else?
This next indication is particularly important, tying back to the age discussion earlier. New fibroadenomas that turn up in patients over 40 should be considered for excision biopsy.
Ah. Right.
So the notes don't explicitly state the reason, but considering it's both a biopsy and removal, the strong implication is you need to definitively rule out malignancy in this older age group, even if it looks and feels like a typical fibroadenoma.
That's a really key point. So a new lump that seems like a fibroadenoma in someone over 40 warrants a higher degree of caution. You have to think about removal and biopsy, even if it feels typical. That age threshold comes up again for management.
Exactly. And finally, the notes state that fibroadenomas that are increasing in size, or ones that show atypical characteristics on previous imaging or biopsy, they require either a repeat biopsy or just going ahead with excisional removal.
Okay, so the main triggers for surgery from these notes are size, 3 centimeters, patient choice, being new in someone older, 40, where you consider excision biopsy, or if it's growing or looking suspicious.
That sums it up well.
And the notes also mention follow-up in general, like regular exams and maybe imaging, depending on the situation, whether it's just being watched or after it's been removed.
Right. Management isn't just the one-off decision. It's also about the ongoing care plan.
Okay, let's wrap this up by looking at the prognosis and potential complications as they're presented in these notes. What's the general outlook for someone diagnosed with a fibroadenoma?
The prognosis, according to the source material, is generally excellent. Fibroadenomas are benign, and importantly, the notes state they are not associated with an increased risk of developing breast cancer.
Oh, that's very reassuring.
It is. That's a really key piece of information from this material. And as we mentioned earlier, they might also regress, shrink, or just remain stable over time.
That lack of association with increased cancer risk is definitely a major takeaway, both for the patient and the clinician managing them. But even with a good prognosis, the notes do list some potential issues. What are the complications mentioned?
The notes list a few things that can potentially complicate the picture. First, psychological distress, which is understandable. Really anxiety and worry related to finding any breast lump, even if it turns out to be benign in the end.
Yeah, it's important that these notes acknowledge the emotional impact, not just the physical side of things.
Absolutely. Then there are potential complications specifically related to surgical management, if that's the path taken. Recurrence is mentioned as a possibility, perhaps if the removal wasn't totally complete.
Makes sense. If you don't get all the tissue that's causing the overgrowth, it could potentially come back.
Exactly. And finally, standard surgical complications are listed, but tailored to breast surgery. Things like infection, bleeding, scarring, potential changes to the breast shape, and maybe altered sensation in the area. These are sort of general risks of any surgery, just highlighted specifically for this context.
Okay. Psychological distress, recurrence after surgery, and those potential surgical complications. That covers the potential downsides listed in the notes.
So yeah, we've walked through the definition, etiology, risk factors, epidemiology, those crucial differential diagnoses, the clinical presentation, investigations, including that key age split for imaging,
Right.
management options and the indications for surgery, and finally, the prognosis and complications, all drawn directly from the source material you provided.
We really have distilled these notes down. And if you're using this as a tool for revision, maybe for exams like the MSRA, locking down those absolute high-yield nuggets is so important. Based on these notes, what are the absolutely crucial points to have ready?
Well, definitely remember it's the most common benign tumor. The core description: firm, rubbery, painless, mobile. Definitely remember the breast mouse.
Got it. Breast mouse.
The primary age group, 15-35 years. That strong hormonal link, especially estrogen, those critical age cutoffs for imaging. Mammography over 40, ultrasound under 35,
Very important.
and the specific indications for surgery. Size greater than 3 centimeters, patient preference, being new in someone over 40, and considering excision biopsy then, or if it's growing or showing atypical features.
Those really feel like the points that jump out from this material as being essential for quick recall in a clinic or exam setting.
I agree.
Thinking about this whole deep dive into these specific notes, even for something so common and generally benign, there are some surprising nuances, aren't there?
Definitely.
Like the fact that the overall UK prevalence isn't actually known, despite it being the most common type, the absolute necessity of considering that differential diagnosis list every single time you encounter a breast lump, even if it feels classic, keeps you sharp, and the acknowledgement of psychological distress alongside the physical aspects. It really highlights that no condition, however common, is entirely without its layers.
It really does. And understanding that list of differentials, it forces you to actively rule things out, rather than just jumping to the most likely diagnosis based on feel alone. It makes you think critically, which is a fundamental skill these notes implicitly encourage, I think.
Absolutely. And getting this level of detail straight from your notes, focusing like this, is exactly the kind of targeted revision needed for challenging exams like the MSRA.
And to help you with that kind of focused preparation, there are some excellent resources available out there that are specifically designed for MSRA revision.
Yeah, you can find incredibly valuable tailored resources built to help you master this kind of material at passthemsra.com and also at freemsra.com. They're really designed to help you integrate and recall these facts effectively.
Use notes like these, use those resources, and just keep making these connections. That focused approach is definitely key to building robust knowledge, not just for exams, but for clinical practice too.